Good afternoon. So I must say this morning's sessions were really tremendous. They were exciting, they were engaging, they were very high in quality and excellence, and I really appreciate everybody's participation. Our next talk is entitled Ombudsperson Approach to Difficult Conversations, and that's to be given by our Ombudsperson, Dr. Michael Myers. Dr. Myers is a professor of clinical psychiatry here at SUNY Downstate Health Sciences University. He's been our ombudsperson for our medical students and served many years on the admissions committee. You know, I think few people, I want to say a few comments here. Few people really appreciate and understand the nature and the extent of what Mike does. And the reason for that is because he does it so well. He handles very difficult situations, difficult conversations with grace, poise, and people come out of it feeling really good. And that is really a special art and a special talent. He is a nationally renowned expert in physician health and student health. And my understanding is that he's co-authored a total of 9 books, unless you've rapidly published the 10th. I wouldn't be surprised. The last one is Becoming a Doctor's Doctor, a memoir. You know, I want to, again, share some more personal insights. When we raised this Kudos and Concerns platform, it was very interesting because before that, virtually all conflict resolutions went through the ombudsperson. And I really believe that Mike was the unsung hero in terms of developing a learning environment committee, and B, developing this rapid response team where all of a sudden he wasn't alone in all of this. It was, you know, Elke and myself and, you know, Ricardo and Taryn, as I explained before. And I guess maybe at the onset, there was some uncertainty of all of our roles. But I think chemistry developed, and, you know, throughout our conversations of various concerns that have been raised, I've learned that you have to handle each one individually. And I could think of nobody in this regard that I have learned the most amount from. So, Mike, I thank you for that. What's more is a typical Renaissance man. In addition to loving his footwear, he plays the piano, swims laps, writes fiction and nonfiction, and really is a man of many talents. So without any further ado, Michael Myers, please come up.
Thank you, Jason. That's a very nice introduction. Wow. Okay. I hope I don't disappoint. This is an important afternoon. It's my pleasure and honor to be here today with all of you and participating in the first LEC Summer Conference. As mentioned, my name is Michael Myers. I invite you to call me Michael, and my pronouns are he, him, his. So let me just start with, okay, my muse, Martin Buber. Why this is relevant that I think of him is the famous book, I, Thou. Because the result, actually the essence of our work, I think those of us who do this kind of work, it's about a relationship, because it's a complaining student with a concern and then somebody that's been complained about. But it's really about humanness, and he talked a lot about mutuality in that relationship and reciprocity. It involves yielding, usually on the part of both of the people. Certainly subjectivity and a quest for clarity, and then communicating meaningfully is the bedrock of human connection and self-regard. So it all started in 2008. Within weeks of arriving, our dean at the time, Dr. Ian Taylor, called me into his office and asked me to take on this position that he had just created. I'm going to read a little bit. I decided to put a lot of things in my memoir, but I particularly wanted to put this piece in because it has a lot. The book, by the way, is not just for us in medicine or people who care about us or treat us. It's also for the general public. And I really wanted them to know a little bit about the inside, the medical workings of the field of medicine. So he asked me to take this on. Dean Taylor and I shared the same ethos that the health of our students was precious and must be safeguarded in their 4 years with us. My task was to evaluate and resolve complaints that medical students had had about being mistreated in the course of their education. By the way, at the time, the medical student graduation questionnaire, which our fourth-year students fill out, there were some very serious concerns, and that's why he wanted me to take this. Mistreatment, either intentional or unintentional, occurs when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process. So broadly defined, this might include, I know for some of you this will be second nature, but for others, you may wonder. It includes being berated or humiliated, a professor, resident teacher being asked to perform personal errands, things like that. Having to do with teaching activities, being harassed because of your race, your gender, ethnicity, religion, sexual orientation, or gender identity. But it causes anxiety. And this can be destabilizing and demoralizing for many students. So what I did, and beyond dealing with the individual complaints, I also decided, and this is where I called upon another muse, Benjamin Franklin, an ounce of prevention is worth a pound of cure. So I learned very quickly that the individuals who had been complained about, they were not bad people. More often, these things had to do with misunderstanding, sometimes being out of step with what's deemed acceptable or professional in our medical academy today. So I decided to meet with each department to explain my role in the medical school. And that took quite a lot of time and work, and those were some difficult conversations as well. Certain of our older professors have struggled with purging their sexist language and mannerisms, and a number of international medical graduates have had to adapt to a teaching context that is so different than that of their country of origin, where they came of age themselves in medicine. And certain physicians have needed to learn that bullying and shaming techniques are not acceptable today, though they may attempt to defend their actions with the time-worn excuse, which is that, well, that's how I was trained. So to drive home my point, I've repeatedly shared a disguised case from my private practice. I'm going to tell you about that now. It's a compelling story. Invariably captures the attention of even the most cynical doctors in the audience. Some of you may have heard this story before. Dr. Jin was a third-year resident in general surgery. He came to see me 6 weeks. By the way, this is a disguised story from my private practice in Vancouver before I moved to New York. 6 weeks after he had begun to fall into a clinical depression. His mood was flat and dull. He had lost 7 pounds of weight. He's having trouble concentrating, et cetera, et cetera. And he wasn't struggling with hopelessness. He had no thoughts of suicide. Now, I had treated him when he was a medical student, and so he'd come back. My notes were almost identical to the way he was presenting now. So the treatment was straightforward. I put him back on the antidepressant that he responded to before, and I made an appointment for him to come back in a week. The night before that appointment, I got a call from his partner, Dr. Rand, who was also a resident. Dr. Rand was in a panic. He had come home from work. He was startled to find Dr. Jin standing out on the balcony of their 21st floor apartment. It was dark, it was the middle of winter, and Dr. Jin seemed to be in some sort of, quote, dazed, altered state, end of quote. He grabbed hold of him, coaxed him back inside, locked the sliding door, and made sure he was safe. They talked for a few minutes, and that seemed to help. Dr. Jin calmed down a bit. They had a light dinner, but still worried. Dr. Rand phoned me. I made a house call that evening. When I asked Dr. Jin about being out on the balcony, he said, and I quote him, "I was debating whether to jump or not." End of quote. He sighed, took a deep breath, and another, I can still remember this so vividly, and added, "Thank God for Alex coming home when he did. I'm not sure what might have happened. I'm okay now, but that was very scary." I expressed my relief too and asked him what might have led up to this. And here's what I learned. Quote, we were making afternoon rounds with my team. I wasn't at my best. I was tired. I'd been up all night in the OR. My attending physician started grilling me at the bedside of one of my patients. I was trying to explain her test results, but I guess I wasn't doing it right or fast enough. He kept interrupting me and asking me questions as if this were an exam. I could feel myself getting more and more anxious, getting more nervous, getting things wrong, contradicting myself. And then he just blew up. Jen, what's your problem? This is a pathetic performance. How'd you get this far in training? I won't embarrass you by asking one of the medical students to answer my question. Questions that any medical student could ace. End of quote. He kept going on and on. It seemed like an eternity. No one said a word. I think they were stunned. You know what happened? My patient spoke up and said to him, Dr. James, forgive me for butting in, but aren't you being a little hard on my doctor? So he stopped. Nothing more was said. We finished the rounds. He left. Two of the other residents talked to me, and that helped a lot. I walked home, but I kept thinking about what had happened. As pissed as I was at Dr. Ames, I thought he was right, that I did do a horrible job at presenting my patient to him, that it was inadequate and inferior. I let myself down. I let my patient down. I let my team down. I began to doubt if I had what it takes to be a good doctor, a capable surgeon, the balls to be tough, not show any weakness. Next thing I knew, I was out on the balcony. I reassessed Dr. Jin and concluded that he was safe to remain at home. This came as a relief to him and to Dr. Rand. He did not want to be hospitalized. We all agreed that he needed a good night's sleep. I saw him the next day in my office and he felt much better, but I put him on medical leave and he needed more time for the antidepressant medicine to begin working again. Within 2 weeks, he was almost back to baseline and I had him return to work. I strongly believe that Dr. Jin could have killed himself. Dr. Rand's coming home when he did was fortuitous and quite possibly saved his life. My message to attending physicians is blunt. Teaching by shaming is unprofessional, never acceptable, and can be dangerous. Even if you were trained this way and obviously survived it, does not make it right. Your trainees may be battling with depression or other illnesses, and although not 100%, they're still able to work and function effectively. Abusive teaching is enough to push them over the edge. So that's the story. But at the end of the day, my educational meetings with the doctors in the various branches of medicine at our medical school here at Downstate have been well received. Medical student complaints about mistreatment have fallen each year, and I continue in this position to today. So that's the piece that I wanted to start off with. So let me tell a little bit more about my backstory. It really is grounded in physician health. I lost, when I was a first-year medical student, I lost one of my fellow medical students. He was my roommate to suicide in 1962. I treated my first physician patient on Christmas Day in 1970. I was a PGY2 resident on call. Now, fast forward to today, and I've treated over 700 medical students and physicians, and I continue to do consultation work. I'm no longer in private practice. So the subtitle of the talk today, having those difficult conversations, being trained in psychiatry certainly prepares you, as you are prepared in many other branches of medicine as well for difficult conversations. But, you know, we have 4 years of it. And also we get to learn new skill sets as well. I'm also trained in couples therapy, skills I've used extensively in my Ombudsperson's work, because I think of all of the couples I've helped in my private practice, especially with contentious relationships, and I've been able to, I have found those helpful as Ombudsperson. For those of you who are just a little peek into what we do, you know, we see people at their most vulnerable. They're really diminished by their symptoms, of course, often crippled by anxiety, plagued by perceptual difficulties, assaults to their thinking, rendered hopeless and despairing by overwhelming depression and so forth. That's what we call impaired judgment when we feel that they're not able to do their work. But we also bear witness to folks too who are also heavily defended and do not have insight. They've got what I call hypertrophied defenses. And the ones, of course, are denial that I didn't do anything wrong. Rationalization, where we blame somebody else for can't take responsibility ourselves. Minimization of the issue, displacement onto others, and intellectualization, which of course we do a lot in medicine because it keeps us sometimes safe to do the work that we do and not completely collapse or cave into compassion fatigue. So, because that's the way it is sometimes when I do have to have a difficult conversation with somebody who has been complained about, they can be very, very defensive. So what else is part of my backstory is that I've been interested in the life of medical students, obviously, since Bill's death. And I started publishing in this area back in 1985, was my first paper on medical students. It was published, as you can see, in the Journal of the American Medical Women's Association. I couldn't get it published anywhere else. And I'm extremely grateful to the American Association of Women in Medicine for taking a chance on this, because it really was talking about something having to do with the vulnerability in the personal lives and family lives of our trainees. So that was in 1985. So that's 35 years ago. And then I published a book on intimate relationships and marriages in medical students in 2000. But also my work has also been a lot with residents and marital issues for them, but also abusive residents. And again, see, that was something that wasn't really talked about until about this time. That was 1996. So that's going back now about 25 years. I want to give you a couple of disguised cases from my private practice. The reason I'm doing this is I have found it very difficult to, even though I've got so many files as Ombudsperson since 2008, it's very hard. I'm very protective of both the students and the people that I've had to speak to. It's hard to disguise those. I will have a couple of those, but most of them I've decided not to speak about. So these are cases from my private practice, but they are related to the subject matter. So the first one is Mr. W, who is a 23-year-old medical student. Now, he had come to see me with his girlfriend. He was already in treatment with me when he experienced what he called something weird. Just a bit about him. He and his girlfriend had been together 3 years. By the time they came to see me, though, their relationship was really on life support. And my task was really helping them to separate with dignity. It was tough for him because he felt pretty abandoned. So he was feeling, kind of wobbly at the time that this quote, something weird happened. So they both stayed with me for individual therapy after the couples therapy was finished. So here's what this was. He'd been skiing the previous weekend. He got to the bottom of the run, and those of you who ski will know this, he was alone, so he yelled out single. And with that, a young woman approached him and to ride up on the chairlift with him, and they recognized each other immediately. She was Dr. C, a senior resident whose service he had rotated on about 4 months earlier. I quote her from him, "Wow, I knew you were a first-rate medical student, but I see you're a hotshot skier too." End of quote. Mr. B felt flattered but nervous and blurted out, "Thanks." And she continued, "No, I'm serious. I've been watching you ski. I'm dazzled. I didn't know it was you though. Now I do. That's even better." So they chatted a bit on the ride up, and he hoped to just say goodbye when they got to the top, when she said, "It's getting late in the day. Let's do one more run and meet up for a beer at the bottom of the mountain. My treat. I make more money than you." End of quote. So he demurred, but she asked again. So he said, okay. But the conversation was just too much for him, too personal. He listened, then made an excuse and drove home. So we spent that session and several others unpacking all of this so that he could make sense of it, because he was no longer her student, but yet there was this history of that. And this was, as he concluded, this would be very different. First of all, if he was feeling better. And secondly, they had met, in a completely neutral situation. He had a plethora of emotions, but he did end up feeling better about himself. But I think what this illustrates, though, is that things like this, though, can be perceived as somewhat traumatic, when even though their formal relationship had ended, but this was very, very difficult for him, 4 months after the conclusion of their professional relationship. So let me tell you now about Dr. O, a 36-year-old PGY4 resident, male, IMG. I saw him about 20 years ago. When I asked him why he came to see me, he said, quote, "My training director told me I have to go see Dr. Myers." End of quote. So here's some dialogue. "All right, so tell me more about that." That's me speaking. "Well, not much more to say. He just said to come here." "Okay, I'm glad you're here. Are you wondering why your training director wants you to see a psychiatrist?" "He told me I'm in trouble." "Trouble? Aren't I being a good psychiatrist, "Yes, I told one of my medical students that she had nice titties." "You what?" Even though I was way beyond mid-career at this time, there's still things in psychiatry that, do give us a little bit of a jolt, because we're trained to be so kind of, that sort of thing. To which then he said, "Yes, I know I made a mistake. I should have told her she had nice breasts." "Excuse me?" So by this point, then I knew something was going on here. I said, "Please explain." I quote him, "I really didn't mean to upset her. I wanted to make her a compliment." He was an IMG, and I won't tell you any more than that, but struggled with English and with idioms. "She is a very beautiful young woman. She also has a beautiful soul. And what an excellent student doctor. She is very intelligent, assertive, and she is so professional with her patients." So I said, okay, well, so tell me what happened. "Well, I made this wrong compliment on the elevator at the hospital. There were just the two of us, just as the doors were about to open. When they did, she took off. I'm not sure where, but a couple of hours later, my training director paged me to come to his office stat. I did. He was red in the face. He asked me to verify what the student told him, and I did. We talked a bit more. He told me to leave the hospital and go home and think about this, and he'll call me later. And he did. He told me I need to be on leave until I am examined. That was last Friday, so here I am today. Oh, one other thing. When I realized later that what I said must have upset the medical student, I told my training director that I want to apologize to her. He said, "Absolutely not. I don't want you going anywhere near her." So I obeyed him, but I feel sick inside. I don't have time to go into all the details of all of this, but with a signed release, I was able to speak to the training director and learned that this was just one of many concerns about this doctor and his performance at work. This collateral information was absolutely essential. And with that, plus a detailed assessment of him, I was able to diagnose him with an atypical depression. One of the main drivers of his depression was his isolation as an IMG and struggling to adjust and to fit in his program and in the city. He knew no one. His wife and 4 children were with her family in his country of origin. He was palpably lonely. Speaking with the training director, I also learned that the medical student had met with the clerkship director and also once met with the school psychologist. When I tell you this story, I want you to understand that I'm not excusing his behavior. I'm just explaining it, because not uncommonly, we psychiatrists, I think, are typecast as not holding our patients responsible for their unprofessional actions. But it was my quest to really try to understand this. So I'm going to turn now to these three disguised complaints from my files here. And the first one is, these are in different categories: cryptic, off-putting comments and jokes about men and women in medicine. So this was a complaint by a female medical student about unprofessional behavior on the part of a physician in the teaching setting. The comments were about whether she and the other medical student were a couple or not. And if not, they should be, despite their racial difference. This was the attending speaking to these two students. He also obliquely and by innuendo told the male resident to be very careful being alone on a one-on-one with female medical students and residents, because medicine is changing rapidly, and quote, men can be misunderstood as having things on their mind that have nothing to do with clinical work, end of quote. Oh, if you know what I mean. That was that sort of innuendo quote. So the student wrote, quote, while I did not take Dr. X's comments very personally, I'm pretty thick-skinned, she added. I believe that his behavior is inappropriate, and I would not like another student to be the recipient of such comments and actions. So how I handled this, because she didn't want to go further, I'll explain other ways that I do things differently. But I got her permission to proceed. And then I contacted this individual. I sent him an email first. And then because his days here at Downstate didn't correspond with my days here, we had to speak over the telephone. But he was really, really shocked and just really upset about this had happened. He felt badly about it. He said that his comments were not directed directly to her, which probably is okay, but it was more, he said it was more to the anesthesiologist. I don't know how much of that was a diversion or whatever, but he really felt misunderstood. He said, it's partly my background, my culture. We joke a lot in the OR because it's very serious work that we do. He said he was to break the ice, et cetera, et cetera. He talked so much about how he loves to teach, et cetera, et cetera. And what he wanted to do was to apologize to her. So what I did with that is that and I've got a copy of my email here. Dear Ms. So-and-so, I just spoke to Dr. X over the telephone. Normally I would meet with the individual in person, et cetera, et cetera. He was upset and surprised about the complaint. He states that he is someone who likes to joke a lot in the OR, to break the ice, to not always have things so serious. He believes that there's been a misunderstanding. He feels badly. He did not mean to embarrass or offend you, and he regrets what he said and did. He wanted to clarify that his comments were made to the anesthesiologist and not to you directly, but he still takes ownership of the inference. He told me that he really likes having medical students in his work and loves teaching. He asked about meeting with you and apologizing. I told him that I would check with you first and find out what you would like to do. And then I gave her a series of options, and then I asked her to get back to me with regard to next steps. So she did, and she said this: thank you for getting back to me. I fully accept Dr. X's apology, though myself and some others in the room were surprised by the comments. I can see how he was only joking and how he did not intend to offend anyone. I do not feel that it's necessary to meet with Dr. X in person, nor do I feel that a written apology from him is necessary at this point. I appreciate all that you have done, and I accept what Dr. X has conveyed to you. So then I got back to him with that feedback, and that's the way that was left. So religiosity in the teaching setting. I've had a lot of these over the years. This one, 2 complaints about attendings asking medical students about their religion and then reacting adversely to their responses, followed by a medical student, quote, diatribe about the secularization of our world, including our medical students. The students witnessed or overheard comments about abortion being equated with murder, that gays are fornicators, and puzzlement as to why some Jewish students wear those little hats on their heads. The students chose the clerkship director as the person to pursue these complaints with, and I followed up, and indeed there was resolution. So this was one of the things then that took that option and route, and it worked out fine. One of the physicians was relieved of his teaching duties and the other quit. These were at satellite teaching centers. And third, abusive, belittling, rude teaching style, creating a hostile work environment. And this is what I would call more than one complaint about an attending at satellite teaching sites whom medical students found sarcastic, excessively demanding of students, relentless grilling on ward rounds, rude toward and disrespectful of residents as well, and negative and hostile work atmosphere. Again, this is another one where my speaking to the clerkship director, the program director as well, and chair of the department. The person has been removed from the clinical teaching faculty. And that was a very high level one because although the residents hadn't complained directly before, with the complaints from medical students, then the residents complained. So let me just kind of come full circle and kind of explain. Here's what I try to bring to the work. The knowledge that the medical student, of course, is upset, confused, frightened, anxious, angry, and committed, quote, to something being done. Plus, not uncommonly ambivalent. And that's why, we've had forms of complaint since the Ombudsperson office was opened, that you could do this online, 2 different versions of that, but they really do prefer to do it differently. And so when I speak with them in person, then there usually is the next feeling is, do I have a complaint here? Do I want to proceed, et cetera, et cetera. But as you can see by the second bullet, if you've read ahead, it's very same in the person that's complained upon, the same kind of host of emotions, with the addition of the embarrassment that the person feels, or the shame that they might feel, how hurt they feel. It's a blow to their self-esteem. And by the way, I'm using the term narcissistic wound or injury not as applied to people with narcissistic personalities. I mean, you see that occasionally in medicine, but it's also used as a general term for all of us when and if there's been some sort of blow to our self-worth or self-esteem or what we do. And that's certainly, what many of these individuals have struggled with when there's been a complaint lodged. So the steps that I take are these. I acknowledge that I've received their complaint by way of email or voice message. And of course, the details vary with what day of the week that might come in, or whether it's at the end of the week, and the sense of urgency. So I've learned this too, that I give them the option of meeting with me in person or Zoom since the pandemic, or speaking over the phone, because some individuals don't want to come in, and they're okay just speaking over the phone. And I also try to sort out a little bit over the phone whether this is specifically as it is, or is there a concern about grades or sexual harassment. And so, as you can see, and there are people in the audience who assist with this, either those will then go to the dean's office, grade complaints, or the Office of Diversity and Inclusion with regard to any kind of harassment, that type of thing. Now, some exceptions to that are those individuals who feel, though, that their grade has something to do with the way that they were treated, that they hadn't spoken about the mistreatment before. And so it's kind of a mixture then that I may then be involved with one of the deans sorting out the grade part, and I'm dealing with the other part of the alleged mistreatment. So I immediately start talking about confidentiality, and I explain my note taking and that the files are locked up, because these things are all very important. And anybody who's actually, lodging a concern, that it's my job to just try to understand, summarize, explain options. And I let them know, because sometimes they're relieved if we just leave it there, or they may or may not come back. But I still give them their options, though. And I also want to correct any things that I think are accurate or inaccurate if they've written something down. So it's largely fact gathering. And, but again, this is why I prefer actually meeting in person if I can, or by Zoom, because then I can sort of kind of get some sort of degree of upset that they might feel about this, or mistrust, et cetera, et cetera. And it's just more intimate. So the fear of retaliation is ubiquitous. And if it doesn't come up, it's the elephant in the room. I've learned long ago that despite that it's written in the policy, and despite the fact that we can say that, there's only so much trust put in that. And I am able, though, to make corrective statements, because sometimes I actually know the individuals, and I just know that these are not going to be individuals who are going to retaliate. I don't kind of put it like that, but I just feel, I think that we can safely proceed. I will help them in that type of thing. And that actually can be quite relieving for them. But on the other hand, though, as in that second bullet I mentioned, I've been around the block, I've worked elsewhere, and I know that there can be some very egregious things that can happen, especially in certain branches of medicine that are small and are very, very competitive. And people who are in powers of position here with national, international reputations, you can see why students would be very, very frightened to complain, because I've also, in my private practice, looked after individuals who are there because of basically being blackballed through something like they started when they were a student, and now they can't proceed with their careers. So when the student hasn't already spoken to the site director, sometimes they may know that, but yet it's so interesting, again, because I know a lot of the site directors, it's interesting how some students are kind of like afraid of or intimidated by the site director. That's the part I can help with, because I know that this is a site director who's very savvy, very tuned in, is able to help. Contact the clerkship director if not done already. That's the area too. And so with that, then they will proceed on their own. Of course, then I want them to get back to me to close the loop. When it's a resident that is the person that's complained about, then this then gets into a whole other area where then the training director needs to know about that. But sometimes, though, I am blocked by the student who doesn't want that to happen, because they're either afraid of getting the resident in trouble or something. There's just a lot of mixed feelings. That's why sometimes it may take a few visits before there's some clarity as to really what the student would like to do next. There's this, what about pure medical student witnesses who bail? This is very common. I'm not sure what to say about this, because the complaint comes in and the student says, will you join me in this? I say, of course, I witnessed this, I saw it, et cetera, et cetera. And then when push comes to shove, the students all bail. So the person goes it alone. And sometimes then they really retract the whole thing. They just don't want to go forward. So I think my message often to peers is to try not to abandon your medical student peer or whatever, that you too can get the support. And we're very sensitive to timing on this, where the student will say, well, I don't want you to do anything until I get my grade. I mean, that's a classic response, et cetera, et cetera. And then also sometimes too, when a student does get their grade, then they don't want to proceed because their grade is better than they thought. And they thought the individual was out to get them, and then they feel that they really weren't, and this sort of thing. Again, it's still not excusing the behavior, but there are times, especially if I'm aware of this with regard to other individuals on faculty, that I try to kind of counsel them or encourage them that it is still okay to go forward with this. But again, I try not to be coercive with any of this, and yet I want to make sure that they are indeed fully informed, because I also want to make sure that I don't become an enabler. The referral to Dr. Deutscher, for those of you who don't know her, she's the head of student counseling, and then she may be involved in situations where the individual medical student complainant has actually become quite symptomatic through all of this. And so she can be very, very helpful in that regard. So I've got some preferred options, of course. And the one that I really like is accompanying the complainant to the requested meeting with the clerkship director. And I've done this with a few clerkship directors now. They invariably have all worked out well. What I like about it is that I'm really just there kind of like as a, I don't know, sidekick, or somebody who's there to be supportive or to vouch for this or whatever, but let them do. See, this then really gives the medical student just so much sense of assertiveness, agency, autonomy, et cetera, et cetera. And as I say, invariably, the clerkship director is very on side, very mature, very open to this, and will want to take it. They keep the communication open. That's why I called it a wholesome outcome. And this final one, which I've only seen once, which is really, really wonderful, is where the student came. This had to do with a micro inequity having to do with racism. And he thought from the get-go that this person that he was complaining about was just basically a nice guy or a decent person, but just not aware of some of his behaviors and language. And so he wanted to do this on his own. And so he did. And the feedback that he gave to me was really very moving, because not only did he feel good about this, but most importantly, the person that he was concerned about was just so grateful to him for having the courage or the assertiveness or whatever to speak to him. He gave him some reading material that he could use to look at his tendency towards sort of microaggressions and things like that. And they even kept in touch, because I bumped into that student down the road, and I just thought that was really, really powerful. So I try to obviously be empathic, being an empathic or being an academic physician myself. It's not a stretch. This could be me. How would I like to be approached? That sort of thing. So I usually send a short email just mentioning I received this, making sure of my availability, because sometimes I get a response within a nanosecond, because this is really upsetting for people. I want to make sure that I'm available either that day, that evening, the next day or something, never the day before you go off on vacation or the end of the week or something like that. And see, by that point, I already have the student's permission, of course, to share the actual complaint. Now, what I do there sometimes is I do, and I tell the student this, that there's things that they've written that I would prefer not to share with the person they're complaining about, because it's judgments usually that they've made about the individual, because they're trying to figure out why would he or she act like that. So then they make these cracks or something, you know. But I really don't feel that that's necessary to share with the person that they're complaining about. So I'm using my judgment, and then they're okay with that as well. They kind of realize that maybe that isn't necessary. So with this, then I like to either give it to the person to read or certainly share it with them. But most importantly, in this next bullet, this is something I've learned over my long career as a doctor's doctor. I can't tell you the number of physicians that have been, quote unquote, sent to me by somebody in authority, where they feel that they were called in and given a litany of concerns about their behavior, and they did not get a chance at all to explain themselves. They weren't invited to, and if they made any attempt to kind of explain, they were shut down as being defensive and not taking responsibility before they really even had a chance to even explain extenuating circumstances or whatever. So I'm very sensitive to that for very, very good reason. So I want to listen carefully to their version, which is often quite different, but not always. Their memory, their details, the background, and as to why they said what they did or acted the way they did. And I learned so much because that really gives a broader context to this as well. The other thing too is that what hasn't been conveyed to me, of course, but is then the person then has some concerns about the particular student that were not voiced to the student. And so the student wouldn't be able to voice them to me, but they make me kind of also wonder, not so much about the authenticity of the student, but also just, what, in other words, this is an interaction. I call it provocative behavior. The student did not share with me or wasn't able to see that he or she was behaving to that person in a provocative way that in part accounted for their behavior, because it's such a highly charged interaction. So, and that's what I mean. That's where I use a lot of my experience with, couples in trying to sort that out. So I find all of that helpful then, because I also have to get back to the student after this as well. And I'm usually able to give in person, hopefully, but not always, some feedback as to how all of this transpired. There's of course a lot of detail that I don't convey. It's not necessary to do that, but it's the sentiment. I think that's what's most important, that I was heard. They took this very seriously. They feel badly about it. I may say their memory isn't quite the same as yours, but that's okay, that sort of thing. And then generally the students are fine with that. What they seem to be pleased with is that something was done and there will be, something come of this. So then I also tell that person too that I will then get back to them as well to let them know that indeed I've spoken with the student. So why getting back to the students is so important? It's because of this negative sense. Well, we complain and nothing changes. I think what is probably more accurate, we complained but got no feedback. I mean, change is slow. And they may not even be aware of change, but getting the feedback, I think, is just so very, very important. As I say, most of them are very grateful. They got a chance to collaborate, gave them agency. I followed through. There's a minority of students then who then kind of like dismiss me, that I can't get back. I get back to them, but they don't return my calls, my emails, or anything like that. And I just have to just leave it open. And because I don't want to be quote unquote harassing them or whatever. My hunch is at one level, they've kind of moved on and just maybe don't want to revisit it or something like that. So that's fine. So my hopes, I'm always hoping, of course, that there'll be resolution with both parties feeling they got something out of this. For the medical student, of course, voicing their concerns works because we want it to work. Because this will set them up, I think, so much better as they go through life when they're going to have to voice other concerns. This sense I feel validated, that change occurs. And then the person complained about the feedback is all part of lifelong learning. I mean, this is our work. It's humbling. I'm not alone. This is happening to other people. Apologies work, because I've certainly facilitated a lot of those. And at the end of the day, isn't it pretty basic? It's all about dignity, kindness, and the courage to confront difficulties. And thank you. I just want to mention that I keep my website pretty up to date. I have a lot of stuff there, a lot of podcasts that I do in so many different areas of work, in teaching students and residents, but also in health and all kinds of things like that that can be a great transmitter of information. Okay, do we have some time for some questions?
So thank you again for this nice presentation. My question is about confidentiality, because not only it doesn't pertain only to medical students, but also to residents or even physicians. When something happens, it's many times hard to for a different program. Let's say when the student goes there or the resident who applies for a residency or a fellowship, etc. It's very hard to get information about what transpired, let's say, with a particular event. And maybe there are legal reasons. Some people sign non-disclosure agreements or whatever that is. But what is your, let's say, opinion on this? Maybe the confidentiality goes sometimes too far, and then the next program has to deal with similar issues that
So let me, if am I understanding your question correctly, that you're saying because of because because they are in training either as medical students or as residents, that this might have to go on their record or something, and this then could be hard in terms of either their dean's letter or.
I mean, isn't it, that's what you mentioned, that there's going to be a confidentiality surrounding this particular event. It doesn't, it's hard to obtain details about what happened, and then led to, let's say, to either a dismissal or to, somebody leaving, etc.
I'm sorry if I'm not.
I think if it's confidential, then are we doing a service to the next program that perhaps is unaware of these issues and then accepts somebody who might have responsive
Yeah.
Oh,
Sometimes, for example, programs have accepted, a resident or a fellow, and in the meantime, the previous program knows that there is an issue, there is probation, remediation, leaves, and the next program knows nothing. So yeah, that's what I want to find out.
well, see, it's probably all of the above in many respects. Having been a training director myself, when it's like, actually, I can give a disguised example of a situation between one of our residents and a medical student that was sorted out. This wasn't something that I felt had to go on the trainee's record. I mean, it wasn't sort of to that degree. In other words, it wasn't a resident that we had to either put on remediation or was already on remediation or on probation in the program, which of course, Ellen, correct me if I'm wrong, but it's really only probation, isn't it, that then remains on the graduate's record at the time that they finished with us? So, yeah, so there is still lots of room within the educational process itself to correct things like this before they, really get to that, that kind of a level. But on the other hand, I do know what you mean, though, because there are individuals who do go from program to program. But again, I think that can work both ways. Sometimes nothing is recorded or whatever, and there's just this sort of sense that program A will do anything to get rid of this person, including not mentioning anything. And so disaster then strikes, of course, in the receiving program. And that's why sometimes savvy training directors, for instance, or even savvy employers really want to take their time with some applications and really do due diligence to just make sure that there's not a smoking gun here or something like that has not come to the surface. So, but how it can also work the other way, I think, is when it's really used against the individual, I think, in a mean-spirited and, well, probably also illegal way. And that's often then when litigation does have to occur on the behalf of the individual. I've seen that more in individuals who have been diagnosed or treated for a psychiatric illness during their training. And it's as if they've been marked in a very stigmatized way when there's actually, a very treatable illness, which was shown even in the program itself. But there are some programs you can't wait to boot somebody because of this without really giving them a fair chance. Now, I know this more through my work with the Committee on Physician Health of the Medical Society of the State of New York, because I do independent medical evaluations. And some programs are absolutely amazing that and I don't mean just the residency programs, but the institutions, they are quite happy to have the person back when and if they're now feeling better, and that they will indeed continue in treatment and something like that. Other places, they want nothing to do with the individual, and that's unfair and I think tragic, and it obviously rankles me, as a psychiatrist.
Well, thank you very much. I agree with you. I'm for to give a chance. You need to give some chances to the person who has a problem. Yeah, thank you.
Thank you. Thanks. Okay, thank you, everybody.